I am Akanksha Pandey, and I welcome you all to today's session on breast radiotherapy from simulation to implementation, organized by Apex Hospital. So it's my honor to invite our chairperson, Dr. Deepak Arora, consultant medical physicist and team leader at the Max Super Specialty Hospital, Padparganj, to take these sessions. So, sir, over to you.
Yeah, thank you. Uh, so I welcome all the participants who are there and those who will benefit from this presentation later on through the YouTube channel. Uh, breast planning has been, from the last 4 decades, if we say we had the 2D planning, then we switched over to 3D planning, and then we have switched over to IMRT, and then later on we have, VMAT, Rapidoc, and now we have APPI, hypofractionation, and ending with proton therapy. And Dr. Kartik is one of the physicists who has almost seen all the type of planning and done the planning physically. So I welcome Dr. Kartik and to take this session. Thank you.
Thank you, sir. Thank you for your brief introduction, and thank you for inviting me for this topic. It's Deepak sir has told that there is a paradigm shift in the planning in last 4 decades. So we will go through everything in this my presentation. I believe everyone has gone through, it's a series of presentation, and I believe we have completed almost every clinical aspect. So now I will not touch the clinical aspect. We will directly go to the planning aspects. It starts from simulation and set implementation. So if you have any questions or any queries, you can type it in the Dropbox. We will clarify it later. Okay. So just to brief a introduction about breast cancer, it is one of the leading cause of cancer related to morbidity, particularly in the women, and maybe the second largest cancer in India itself in the women category. And radiation therapy is a integral part for breast cancer treatment in our multimodality treatment. So we need to have a precise simulation as well as precise planning that will enhance the treatment effectiveness as well as at the same time minimize the toxicity related to radiation, because we have all know that radiation have their inherent toxicities to the when it has been exposed to any organ at risk. Okay, so particularly this presentation I will be covering mainly the role of simulation in RT. Then we will explore the treatment planning steps, types of treatment planning. Then we will learn about RT delivery in breast cancer. How do we deliver them? And in some few challenges as well as the critical consideration during the treatment of breast cancer with radiation. Now, to start with the importance of radiation therapy, as I told, it is an integral part. So we use almost all the patient in case of post-surgery, whatever be the surgery, maybe lumpectomy or mastectomy, radiation is an integral part. It improves survival in early stages and locally advanced diseases, and there are many a number of publications you can go through that, and many a number of institutions they are following and they have been published, as well as it can be used in palliative settings and metastatic setting for the pain relief. So this is a very good what you call the publication which says that radiation is a very good tool to control the palliation. Okay, so to do the radiation therapy, we have to go through different steps. It starts with positioning, then the immobilization, followed by simulation. Then we go with the target volume delineation. Then we will go for the treatment planning, which includes the dose and fractionation. Then we go for the setup verification and at last delivery of the treatment. So we will go through each steps separately. Patient positioning. So I will be covering patient positioning and immobilization altogether. As we know, positioning and immobilization is one of the crucial parts for the radiation therapy. Why? Because it helps in accurate delivery of the dose, and the same time it helps with respect to your immobilization or positioning. We can spare the critical organs or critical tissue. So in case of positioning and immobilization, our primary goal should be it should be a reproducible positioning. Means it should be reproduced multiple times without any hiccups. And it have minimal position related to error. And it should be a simple one so that daily setup time will be less as possible. So we can quickly position the patient, because more the time taken by the positioning the patient, more will be the error included. So this is the one of the way we position the patient at our center, but I will go through everything. So we always try to position the patient in the supine because it is most comfortable position. We try to put our arms abducted externally and rotated, and it should be holding the bars as shown in this figure. Just a minute, I will take the laser point. Okay, like this. So it helps us to move the arms out of our treatment area of the breast. Okay, head can be positioned straight. In this picture the head is positioned straight, but in case if patient is comfortable, then we can rotate to the opposite side so that we can spare the opposite side of the face. There are other ways is the breastport. So in this breastport, it is an inclined plane that is adjustable to an angle from 5 degree to 15 degree. This will help us to position the patient for our planning purpose that we will discuss later, and has a wedge at the end to prevent the patient from the slide down, because as we have elevated the patient, there is a chance the patient may slips down. Okay. Or otherwise, we can use this wing board. This wing board is the simpler thing that can be used particularly in case of a narrow bore, because in this breast board, we have to position the arm outside so that in some cases, it's very difficult to do the CT scan with the arms abducted and positions like this. So we have to go for wing board, because there the arm position will not go beyond this wing board. And the main drawback of this is that we cannot have this inclination that we can do with this wedge inclination with the help of breastport. Okay, so first of all, to choose with what type of your positioning device, it should be a carbon fiber. The best thing of carbon fiber, you can put the beam from the posterior side. And this, as I told you, this inclination helps the chest wall to be horizontal to the couch, so that it will be helpful in our planning. Arms out of the beam, this will help us arms out of the beam in both the cases. And with the help of this breastport, we can use a ORFID to immobilize the patient. As I told you, alternate of the breastport are you can use foam blocks to get this wedging effect that I have shown in this picture, that you have foams of different wedge angles, so that can be used to get this chest wall horizontal, Okay. Other things that we positioningly mainly use, prone breast boards. They are very rarely used, but particularly they are used when the breast is very bulky or pendulous. Because the moment you have a pendulous breast, that will fall down towards the lateral side, and that will give us a difficulty while we are planning, that I have shown you in this particular picture. So with the help of this prone base plate, so pendulous breast will be fall down and it will be out of your organelles like lung and heart. So you can see over here, the dose is confined to the breast. At the same time, when it is in supine position, you have a very high dose outside towards the lung as well. So in some cases, prone base plate has been used, but they are little, what you are say, it is not that much comfortable like supine position for the patient, and sometimes it is very difficult to get it reproducible on daily life. As I told you, to immobilize the patient, we use different type of immobilizing devices. That starts from thermoplastic mask that we wrap around the patient so that during the treatment, the position of the breast should be intact. Or in some cases, you are not using the base plate or you are not using the breastboard, then we can use backlocks that will take the shape of the and position of the arm as well as the body, and that can be reproducible. Alpha cradle is a type of backlock only. Wireless bra, in some cases we use wireless bra to get this what you call the position of the breast reproducible. Breast ring like this, or breast cup or stocking in case of there is a bulky breast and the patient is not comfortable with the prone position, then we can use these things to get the position of the bulky breast. At the same time, we can achieve this type of dose distribution so that we can what you call to spare the organelles like lung and heart. So once the positioning and simulation, immobilization done, we go for a simulation. The simulation can be done with a conventional simulator as well as a CT simulator. So for the simulation, what we generally do, we mark the scar and range site for the proper visualization during the simulation or during the treatment planning. And field border can be identified with radioepic markers if it is required clinically. And breast tissue also are sometimes marked so that they can be identified on a CT or on a conventional simulator. And along with that, we put tattoo and skin marking to get the reproducibility of the patient on daily basis. When we position the patient on daily basis, we need this tattoo or skin markings to get it reproducible quickly. So if we are going for CT scan best, so the CT scan should be in the order of 2 to 5 mm. It is a institutional based protocol, so it depends on institution to institution. As per your institution protocol, you can go for 2 to 5 millimeter. And coverage of the scan should be from the chin to upper abdomen. Again, it is a clinical call. Okay, how much upper or lower extension you want to take, that depends on the what you call the extensiveness of the target. Okay, we use MRI or PET for the better visualization of the target, particularly in the breast conservation radiation. So we can fuse them, and we can, because some of the target depend on the positioning of the what you call tumor. So we fuse them with PET and MRI for better visualization of the target or tumor. So when we have done the immobilization, then the next step is the target volume. What target we are going to plan, or what is the area that we want to get irradiated with, and what are the area that we have to spare them. So for BCS, breast conservation surgery, your target area will be whole breast or along with the lumpectomy cavity boost area, and regional nodes as per the staging of the what you call the tumor. For MRM case, it will be the whole chest wall. Mastectomy scare should be included, and regional nodes as per the clinical requirement. Now, so your target is, we always call the CTV, is the clinical target volume, which is the tumor bed. It may be the whole breast or chest wall plus regional nodes. Apart from that, for planning purpose, we give a planning target volume. This is the CTV with some added margin. That margin is encountering the daily motion setup, daily motion during the treatment, as well as setup variability. Means on the daily basis, whatever be the setup, setup uncertainty that you are expecting during the treatment. So it is again a institutional protocol. So depending on your institution protocol or institution setup variability, you can keep the margins. And OR includes the heart, lung, contralateral breast, brachial plexus, and etc. Like spinal cord and everything. And usual dose. So in a conventional regime, we give around 50 gray to 25 fraction that will be delivered over 5 fractions. But in a hypofractionated regime, it will be 40 gray in 15 fraction or 42.5 gray in 16 fraction, depend on the clinical consideration. Along with the boost for the tumor bed in case of BCS, that may be a 16 gray 8 fraction over 1.5 weeks with 2 gray per fraction, or 10 gray in 5 fraction or 4 fraction over 1 week, depending on the clinician. And lymph nodes, the lymph nodes may be 50 gray 25 fraction in 5 weeks for a conventional regime, but it will be 40 gray 15 fraction in case of your hypofractionated regime, or 42.5 gray in 16 fraction in hypofractionated regime. So once the contouring is done, then we get it for the treatment planning, which is the whole soul of this, what you call this presentation. That so in treatment planning, we have different type of plannings that, as Dr. Deepak told in the initial, okay, we started with 2D based planning, followed by 3D based planning, then intensity modulated radiotherapy, followed by volumetric modulated arc therapy, and others. So there is a paradigm shift in the planning over last 3 to 4 decades. So we will go through each and everything one by one. Conventional planning. In set of conventional planning, we first find out what are the area that we want to treat. So particularly in conventional planning, we generally use 2 tangential fields that will cover the whole chest, whole breast, or the chest wall. An additional field we generally give for all these lymph, what do you call, nodes like SCF, IMC, or axillary boost. The cranial border is always 2 centimeter from the angle of Lewis or head of the clavicle, depending on the if it is you are treating with SCF or not. Because if you are treating with SCF, then you have to come down a little bit. And the medial border is always 1 centimeter beyond the midline. The lateral border is 2 centimeter beyond all palpable breast tissue or mid-axillary line. And the lower border is 2 centimeter from inframammary fold, which of opposite breast if in inframammary fold in case of BCS, but if it is a MRM case, then it is 2 centimeter below the inframammary fold. But these are the borders, and that can be modified in order to cover the breast, because person to person, the variability of the breast will be there. So you should also consider the whole breast should be covered while taking the margins. Then once you put what you call defined your area of the treatment in case of 2D, then we go for a beam. So for the beam, what we generally use lead wires along the borders to find out in a X-ray or the radiograph film. So what we do, we position the gantry at the 0 and position center of the field at the medial line, medial border. Then rotate to the gantry angle of in 2D we generally use 50 for right side breasted, 50 degree for medial tangential, and 230 degree for lateral tangential, and for left side it is 300 and 130 degree. So we rotate till we get a exact clearance of the whole breast at the 50 degree. And if there is no clearance, then we increase the field size outside so that it will be around 1.5 centimeters out from the surface of the breast on the radiograph. Okay. And for the medial tangential, it is 180 degree opposite to that. Okay. And we at that same time, we should see the 1 to 3 centimeter lung is visible on the simulator, which is not visible over here very clearly, but you can see the lung over here. And when you go for the, when you are using the conventional simulator, you also take care of the wires. Okay, your center, your edge of the beam should be coinciding with the your lead wire at the posterior edge of the portal. Now, in other way, when we don't have a simulator, then we can detect the gantry angle. We can go for the our fixed gantry angle, like as I told you, 50 degree and 230 and 300 and 130. We can take a shape of the breast with the help of a POP or a lead, and you can mark them on a paper, and now you have a breast contour outside. Now on that breast contour, this is the medial line, and this is the tangent lateral line. So from there you put this beam. So you have this beam. Now you angle it out to coincide with the this black line, which is the what you call the base of the or the lateral border of the field. And from here you can find it out, okay, what are the angle it should be used. So in case of a patient with varied anatomy, you can use this type of tools to get the angle if you are not what you call to okay with the standard angles of 50 degree and 230 degree, like that. And coming to supraclavicular or axillary field, the inferior border is determined by the match line with the tangential field. As I told you, okay, superior border of the breast or chest wall field, we put it somewhere here. Now, when you go for SCF, you should be fixing your inferior border at this place, and superior border radiologically, it is usually the superior most portion of the first rib. Okay, and laterally it is 2/3 of the humeral head. In some patients you can go little less. If you are going to the humeral head, then you have to block the humeral head. Medially, the setup is to the center of supranatural notch. Okay, and then the gantry angle, and you should block the humerus head, as I told you, if you go laterally beyond the humerus head. And the inferior is the most important. You have to fix it to the superior border of the chest wall or breast field. Now, this is the 2D planning when you have only radiographs. Now, coming to 3D planning, in 2D that we have seen, we have only one axial size in case of your POP, or you have planar radiograph films on that, or you have a conventional simulator. Using that, you are doing your beam positioning as well as beam angle. But in 3D, you have a 3D volumetric data. And on the basis of this 3D volumetric data, you can find out the beam angles and you can position the beam while seeing whole of the breast as well as all the other normal organs. So in case of 2D, you are doing with radiograph films, but in case of 3D, you can go with 3D volumetric visualization. So when we go with 3D, so we can do the divergence matching technique also. What is the divergence matching technique? When you have a beam, you can see the beams will diverge because we know we have a conical beam. It's not a flat beam. So you have a divergence over here when you are using two tangential opposite lateral fields. So if I will draw a line over here, now So straight. It's not straight. Okay. So if I draw a straight line over here, you can see this much part is what you call irradiated more because of the divergence of the field. So instead of using a what you called a parallel opposed field, we can angle a little bit, means instead of going with 180, we can do 181 or 182 depending on the position of the lateral beam. That will be straight, so that the divergence, that extra dose due to divergence will be omitted. Or otherwise, what we do, we will put our center of the beam at this level and we block one side of the jaw, so that at the center of beam it will be not diverging and you will get the same result what we are getting with the divergence matching technique. So generally we do, if you have a asymmetric jaw, it's better to go with half beam block technique. So now, if you have, as I told you, for the supraclavicular field, there will be a junction, because below this, there will be a chest wall field that will be treated with two tangential fields, lateral tangential and medial tangential field. At the same time, your SCF will be treated with a simple anterior field. So we have to be very careful at the junction of the field, because as I told, we need to have a waist position, inclined position for the patient, because if you want to cover whole the breast, you see over here, you have to give little bit of collimation, because if you will not give a little bit of collimation, this part of the lung will be irradiated more. So to spare this part of the lung, as well as at the same time covering the whole breast, you need to have a collimated what you call the lateral tangential and medial tangential, means chest wall fields. And when you try to do a what you call interior SCF field, this much part of the beam will be common in both the, so you have a hotspot over here. The contribution will be coming from the all the three fields. So to avoid this, what you can do, if you have not inclined the patient, or in some way you don't have a positioning device that can incline, then you have to go for a non-coplanar field like this, so that you will maintain the divergence of the tangential field, or you will match the divergence of the tangential field with the help of a non-coplanar field for the SCF. Or otherwise, what you will do, you will incline the patient up, so that now you are okay with 0 collimeter angle, and treat with a simple anterior field with half beam block, so that it will solve the matching field problem. Okay. This is the problem, what you call, this is the problem that you get matching of the fields in case of SCF. What else if you are treating the patient with a IMC node? So you know the IMC node is over here. So to treat the IMC node, we generally what we do, either we will treat with a what you call wide tangent angle. As I told you, it is 1 centimeter from the midline. In case of that, we go beyond that and we want to cover this IMC over here. But what in the resultant, what will happen? That this part of the heart and this part of the lung will be irradiated more. Or to avoid that, what we can do, we can, instead of putting it in a wide tangential angle, we can give a simple anterior only to the IMC chain, IMC node. So if you are going with the IMC node, again you are end up with this type of junction field junction, and it is more hot. So to avoid this, what we generally do, we make a separation, or we try to make a junction not at the inside the beam, but at the skin level, so that this junction can be avoided. Or we can treat with this with photon or as well as electron, but in both the cases we have to treat like this way. Along with that, while considering the treating the patients with 3D CRT or 2D, we utilize the wedges. As I told, when we give two parallel opposed medial tangential and lateral tangential, you can see over here the thickness or the amount of tissue along this line, or along this line, it gradually decreases when we go to the edge of the skin. So it means your depth decreases. Depth decreases means your dose increases, or there is a loss of tissue over here, like this much part and this much part. Because of this, you will get a very high dose at the apex of the your breast, and you will have a low dose area at the chest wall region. To avoid this, either we can use different type of wedges. Okay, these wedges act like a tissue compensator, so that we can use or we can get a uniform dose all over the breast. Sometimes, means in case of MRM cases, mastectomy cases, we need a skin dose. As we know, 6 MV photon has a Dmax at 1.5 centimeter, and the skin dose is around 66 to 67%. So at the skin, you will be getting only 66 to 67%. So to get that dose over here, what we do, we put a tissue equivalent material over here, so that the dose will be pulled to the skin level. So like this. So this is the dose at the at the 2 centimeter. You want a 100% dose. Sorry, 100% is at the 2 centimeter, but at the skin level or at this level at 1 centimeter, 1.5 centimeter, you are getting around 90% of dose. Now what we will do, we'll put a bolus, or we will put a tissue equivalent material. So this build-up region will be in the bolus, and we will getting a higher dose at the skin level. So these are the consideration that we take in case of 2D and 3D planning. In the view of beams, we generally use 4 to 6 MB, and 6 MB is preferred, because the 4 MB, 6 MB, why the problem with 6 MB, the higher energies underdose at the superficial tissue or at the skin level. However, if there is the separation is very high, then we can go for a more higher energy like 10 MB or 15 MB, or combination of 10 MB, 15 MB with 6 MB to get a better dose uniformity. At the same time, you can use MLCs or multi-leaf collimator. As I told you, okay, over here, if we don't have a multi-leaf collimator, we have to irradiate this part of the lung while putting only with the jaws. Okay, or over here, this part of the lung has been irradiated more while we are treating whole the chest or whole the breast. If we have a MLC, we could have managed to block this area and get managed to reduce the dose to the lung side. Okay, so and the amount of lung included in the irradiated volume is greatly influenced by the postures used, and various parameters are used to determine the amount of lung or heart in the tangential field should be used in case of your 2D or 3D plans. So now see over here, we are treating with two tangential fields, and the amount of lung is irradiating is 1.7 centimeter around. So if you increase the depth or the if you increase this amount of depth, then your amount of lung will be increasing. And there is a very good what you call publication that shows if you have a 1.5 centimeter of your lung has been treated or in the field size, that will be giving 6% of irradiated lung. If it is 2.5%, it will becoming 16%, and if you more will be 3.5 centimeter, it should be 26%. So our depth should be as low as possible, and it should be less than 3 centimeter. And in worst cases, it can go up to 3 centimeter and never go beyond 4 to 4.5 centimeter, because it will give a very high dose to the lung. So what are the problem with 2D and 3D plans, so that we have to shift to the IMRT, VMAT or other planning techniques? First of all, this is very consumption, as we have to take care of the field matching. We have to take care of the all these external devices like wedges or bolus or other things. And the second is dose uniformity. It's very difficult to get a very uniform dose all over the target. And as we know, always the what you call the target in case of breast is concave shapes, but whatever we are treating is a straight line based. So this much area, whatever you do, you cannot spare, because the moment you want to put the MLC over here, uh, your target will be spared. So that we cannot do. So this much of area of the lung, heart, and LAD will be get irradiated when we do the plans with 2D or 3D. So we have to move forward to a, these all are called forward planning. We have to go for inverse planning to get this concave dose distribution. So what are the inverse plannings? The main inverse planning that mainly we use are IMRT, intensity modulated radiotherapy, and VMAT is volumetric modulated arc therapy. Both IMRT and VMAT are sort of an advanced radiotherapy technique that will deliver very conformal radiation doses to the tumor. At the same time, it tried to minimize the dose to the healthy tissue, like all the organ at risk, and it will enhance the efficacy of the treatment, and in some cases, it will reduce the treatment time. So if I say about IMRT, the radiation beam is delivered in a step and shoot or sliding window approach. Like we have multiple fields. Like in 2D or 3D, we are using 2 fields or 3 fields, depending on we are treating any nodal region or not, or 4 fields if you are going with IMC. But in case of IMRT, we may use more fields. Okay, and the dose will be optimized in the sense the modulated means few part of the beam will be, or few portion of the beam will be delivering higher dose and few percent lower dose, so that you will get a uniform dose all over the target. And particularly the linear accelerator delivers this with multiple fixed beam. Each beam angle has multiple segments. As I told, they have divided into the segments so that they will vary the dose in different segments and will get a desired uniform dose distribution. And when the machine is moving from one angle to another angle, the treatment will be stopped. And this modulation is done by the MLC. And the most, what you call it, annoying part is key, the treatment time is, delivery is little high. At the same time, VMAT is again an inverse planning process, where here only the MLC speed is modulated. In case of VMAT, you have a modulation of dose rate. The amount of dose per second will be, or per minute will be varied. At the same time, gantry speed as well as multi-leaf collimator position will be varied. And this will allow a very highly conformal dose, and the treatment time is relatively less compared to IMRT. So what we need for the inverse planning? So mainly we need targets to be controlled as per guidelines available. I think you have already covered all type of guidelines for the contouring, and the OAR should be delineated properly, because we have to, on the basis of delineation of OAR only, we have to plan the, we have to plan this IMRT and VMAT plans, and the dose has to be prescribed. These 2-3 things are needed to go for any type of inverse planning. And dose prescription that I have discussed earlier, the same dose prescription for the IMRT or VMAT, because dose we are not what you call altering, we are just altering the treatment delivery process. And these are the OR constraints. This one is the for the conventional regime, and this one for the your hypofractionated regime. And I have got it from the Quantec. You can follow that. So for IMRT, we have different type of IMRT, what you call techniques or ways. So either you go for a tangential IMRT where you use two tangential beams and you try to do the optimization with two tangential fields that we do with the 3D CRT. Or you can go for a tangential butterfly fields where instead of going with two tangential field, we add another two fields with 15 to 20 degree apart going towards out, so that will help to reduce the exit dose that I have seen over here, what we are getting in case of 3D plans with the help of, because the moment I will give a beam like this, then this part of the tissue will be avoided from this beam and the same from the this beam. So we utilize another two beams to get rid of the dose from the exit point of the beams. Or you can go for a multiple field. But the drawback of getting the multiple field, you can see over here, this blue area shows the low dose area. So you are increasing the low dose area, because in case of your tangential beams, your your beam enters from here and exits from other side of the tangent. But when you are using multiple fields, the fields which is incidenting towards the breast will be exit towards the lung. So you have a higher smaller dose or low dose area in the lung that you have to accept to get benefit of all this dose conformity. So again, the selection of planning is based on the target and adjacent OARs. If your OARs allows you to go for a tangential field, start with the tangential field. Otherwise, go for you can increase your beams, because the moment you are increasing beam, you are increasing the low dose area towards all the organ at risk. Coming to arc therapy or VMAT, again same, either you can go for a butterfly arc if your OARs allow us to go for this only this much of area. The best thing of going from IMRT to arc, you are increasing the number of fields, because over this arc length there will be around 30 to 40 beams that you are getting only two beams in case of IMRT. Or you can go for a smaller arc length or a very big arc length as per your target, and you plan above that. Again, the moment you are increasing the arc length, you are increasing the dose or low dose to the OARs. Okay, so these are the techniques that we mainly use to treat a breast. But in all cases, we can avoid or we can do a little bit of converge of the doses, but not fully, because you will have some dose, low dose area towards the OARs like lung and the heart. And in case of left-sided breast cancer, your heart is near to the chest wall, and this has been uh, and if you try to treat the chest wall, the heart dose increases, and where the rate of cardiac morbidity and mortality increases with increase in the mean heart dose. Means once the heart comes near, if it goes or nearby, then your heart dose will increase, and accordingly your morbidity or mortality will increase. And it is well published. There are number of publications, you can go through that. So to avoid that, what we use, we call it deep inspiratory breath hold. So this is the way your heart positioned for a normal CT. Now, if you want to, you ask the patient to take a deep breath, then your lung expands and your chest expands, and that will give rise to a distance between the chest wall to heart. And this will allow, means now you can see over here, when you put a beam like this to cover whole the breast, you are treating this much part of the heart, and there will be some low dose over this part of the heart. Now, in case of DIBH, you are fully avoided the heart. Now you can go through the 3D view of also, or in other angles also, you can see over here. Here it is showing this much of heart, but when you go to the whole picture, the heart, almost like 15 to 20% of the heart is inside your treatment beam. But in case of DIBH, you have able to hold the heart from the treatment field. So, what to have a deep inspiratory breath hold, what has to be done? The patient is asked to take a deep breath and hold it for minimum of 20 seconds, and more the time will be more the what you call the hold time is more, better will be the treatment, and quicker will be the treatment. So during the breath hold, the radiation is delivered to the desired location. This breath hold position often allows the heart to move out of the treatment field, as we saw over here. It allows to give us a breathing area so that we can put our beam and at the same time spare the heart. Patient has been coached over multiple days. Before going for DIBH treatment, we allow the patient to coach over multiple days, like 3 to 4 days, to get this breathing pattern better and reproducible, so that we can have a good scan over that breathing pattern, and we will deliver that treatment over that breathing pattern, breath hold position. So if you see a particular breathing cycle like this is the regular breathing cycle. Now what we do, we ask the patient to take a breath in, hold it for some times, like 15 to 20 seconds, that as I told you, and allow the patient to breathe out. So during this breath hold, we have a level over here. That is again an institutional protocol. Depending on your PTV margin and the movement of your chest wall, you can decide this. And your beam on will be once the patient start to hold the breath. After a second, the machine will start delivering the treatment over this time. And before the asking the patient to breathe out, beam will be switched off. So during the breath hold position, the treatment will be delivered. So in the market, there are different type of DIBH things, DIBH, what you call, techniques are there, that divided into two types. One we call moderate DIBH, and the second one we call voluntary DIBH. In the moderate DIBH, what we do, we try to control the breathing with respect to amount of air inhaled. So we ask the patient to take some air inside, and we ask the system, okay, after a certain amount of air intake, it will stop taking the air, and the patient will be blocked. The nose is blocked, the mouth is blocked. Now the patient is blocked for the what you call any air inhale or exhale. So this will give rise to a breath hold position, and the patient will be what you call given with a switch, that at any point of time he or she can be she can release it and release the air. Now like that, we have a spirometry system also. This is the what you call ABC system. This is a spirometry system. Both works on the same way. Okay. Now coming to voluntary DIBH. So this both works on the principle of amount of air has been taken and volume of the air has been taken. Once this volume is reached, they will stop the breathing. They will block the breathing. Okay. In voluntary DIBH, the patient has to ask by himself. He has to take a deep breath, and we will ask at some point, okay, hold the deep. Means it is voluntary. Means it's based on patient's comfort. So what we do, we have an external device that will monitor the surface of the body, and it will see, okay, patient is taking that breath, and your chest is what you call your chest is going up, and at some point when we ask the patient to hold the breath, the chest will be at one position like this. Over here, you can see over here, this is the area that we are monitoring, and we ask the patient to take a deep breath and hold, and now we are monitoring the same area, and this area is within this limit. Means it is stopped somewhere. So limit is around 3 millimeters. So it is within the 3 millimeter of movement. Otherwise, your chest wall movement will be around 1 to 1.5 centimeter. So that is called the voluntary DIBH. So there are different ways we can do the voluntary DIBH, like LINRT based or C rate based or RPM based. Here we ask the patient to take a deep breath. He will take a deep breath and hold as per our instruction. And when we say, okay, breathe out, it will get the breathe out. So it's based on you and the patient's comfort and patient's how much percentage accommodating to that breathing pattern. Okay. And otherwise you can do with the laser also. If you don't have any type of this devices, you can go with the laser. Now you have marked a position over here and ask the patient to take a DIBH, then it goes up and you mark over here and you monitor with the video camera and follow the breathing pattern. So this is the type of DIBHs that available in the market. On the base of this DIBH scan, now you have a 3D scan on this DIBH. Now you can do whatever planning you want to do. You want to do a 3D plan, you want to do a IMRT plan, or you want to do a VMAT plan, depending the breathing depending on the breathing capability of the patient. If the patient can breathe for a longer period of time, as I told you, IMRT takes longer time, so you can go with the IMRT plan and give the treatment with IMRT, or if not, then you have to choose between 3DCR to VMAT, whatever the planning system that you are having. So these are the way that we do plan for breast. And coming to next is the quality assurance and delivery. So before each plan, as we told you, for forward plannings like 3D CRT and 2D plan, we won't do any quality assurance. We have to do some machine quality assurance, that is more than enough. But if you are going with any inverse planning where you are modulating the MLC speed, you are modulating the gantry speed, you are modulating the your dose rate, and your dose is delivered from the different angles. So you have to be very careful with respect to delivery aspect of the plan. Means it has been modulated to get a very good result, but on couch, on patient, is it delivering or not? So what we do, we just transfer the our planned plan to a phantom and irradiated with this on the phantom and measure it whatever we have planned and whatever we have got and match them with respect to the gamma percentage, and we check, okay, is this plan is deliverable or not, or if it is deliverable, how much accurately it is delivering. So this is very, very important while we doing any type of inverse planning before the treatment. To the delivery, again, if we have planned something, if we are not getting the same plan to be delivered at the same position, then all of our work is going to waste. So what we do match with orthogonal KB images or CBCT images. Now orthogonal KB images will show you on an orthogonal set of images, okay, you are at the center, your iso center is positioned well or not, or your target area is well covering in that or not. But this is a very images. But if you have a CBCT or cone beam CT, then you can see that on 3D and you can easily deliver that treatment. Is it possible that will be maintained every day over a period of 4 to 5 weeks? No, it may happen. There will be a in case of breast, you have a you may encounter seromas, you may encounter sagging of the breast, you may encounter your breast has got hardened. In that case, your shape will change and you have to adapt to the new shape. So you have to check regularly with all these our daily positioning verification images, and if it is required for replanning, then we have to go for a replan or adapt the plan. So these are the all planning aspects that we should take care for a breast patient. Now, as Dr. Deepak has already told, I have been blessed to work with proton therapy. Now, whatever we have discussed is based on photon therapy with multiple beams. When you come to proton therapy, it's a entirely different paradigm shift, you can say, because if you see your photon curve with respect to depth is a exponential curve. But in case of proton, it is something like there is, if you see over here, if it is the, this shows the depth and this shows the dose, at the surface, you have a very small dose. Gradually, it increases to the Dmax and exponentially it decreases. Suppose this is the tumor over here. Okay. And you want to deliver some dose over this place, then you have to give a very higher dose at the skin level or entry of the beam level. Okay. So you utilize multiple beams to get it uniform all over the target area or all over the field area. But in case of proton, it is little different. In case of proton, the dose to the skin is relatively less and it is almost like constant to some depth. After that, it increases and it stays a constant for some depth depending on the energy. Then there is no dose over there. But in case of photon, you have this much of dose over after this depth also. Okay. So in case of photon, when you try to deliver X 100% of amount of dose over here, you will be ending up 120 to 130% depending on the depth at the skin level. But in case of proton, you will get 100% of dose in the tumor. At the same time, you are getting 60 to 70% of dose at the entry level. And beyond the tumor, there is no dose. So that has been utilized for the breast cancer. So what we do, we treat with a single field like this way and try to treat this much of area of the breast like this. So you can see over here. So we have given a almost uniform dose over here in this depth. After that, there is no dose. But in photon, you can see there is a low dose area all over here. If you go much lower dose, you will see a bigger lower dose area. But in proton, it will be like this. So you are sparing the heart and long dose much more effectively compared to X-ray. But it has all other, what you call it, drawbacks, or you will not say drawbacks, but limitations that you have to follow. Just for the planning aspect that I'm saying, there is an option of proton therapy that will give very less dose to the heart and lung. In fact, with photon, we told you that DIBH will help you to reduce the heart dose, but with proton, without DIBH, we will get much more sparing of the heart with proton compared to photon. Other methods includes interstitial brachytherapy or intraoperative brachytherapy that we generally use for APBI cases and boost cases. I'm not going more into this, but yes, there are options of brachytherapy, and we know with brachytherapy we can give a very high dose at the center of the target. At the same time, the peripheral dose will be very less, and the same can be achieved with the intraoperative or your superficial dose. So this is all about all type of plannings that we generally encounter in case of breast cases. So to conclude my presentation, the simulation and planning are very essential for effective and safe radiotherapy implementation or delivery. Proper technique will improve the outcome and the same type reduce recurrences and spare the dose to the organ at risk. And multidisciplinary approach ensure a comprehensive care that we all know. So thank you. Any questions?
Thank you so much.
Thank you very much, sir, for your presentation. Myself, Upendra Giri, and very thank you, sir. So some of there is some question in the chat box,
Okay.
so you can just answer the question, sir.
Okay, to answer with how do we ensure accurate dose calculation in patients with tissue homogeneities, implants or large breast? Okay. See, that to encounter with tissue heterogeneities, now almost all the planning systems are what you called taking care of these heterogeneities. Okay, but it is taking care of heterogeneities with respect to all type of tissues, bones, not any foreign materials or foreign implants. If you have a foreign implant, then you have to assign that foreign implant and you have to assign the HU that will calculate the what you call the stopping power. Oh, sorry, not stopping power, electron density, and it will calculate. It will help you to calculate, or it will help you to accurately calculate the dose. So preferably, okay, in case of all implants and heterogeneities, preferable what you called your algorithm should be multi-cargo. Okay, but to a practical base, no one is giving you a proper Monte Carlo, but modified Monte Carlo, because proper Monte Carlo calculation takes very long time, but practically that is not possible to do. So people has come up with the ideas that can encounter or that can handle these heterogeneities with modified Monte Carlo, like in what you call in Monaco, or if you come to sorry,
Accuro.
variant
Accuro.
Accurus. Yes. Yeah, sir.
Okay. I would like to add a few comments for the audience. Hello.
Yes, sir. Go ahead.
Uh, one thing is when we are talking about DIBH, the CT scanner which we are buying should have same compatible equipment as we are going to have on the Linux preferably. And second is that Linux should have a gated CBCT feature, because sometimes the supplier make it optional. But also when you are asking for DIBH, you should insist that we get gated CBC. And second part is the electron boost. I mean, the team, the physics team as well as RTT team should have a tabletop styrofoam cutter and define the boost target volume, and then cut the styrofoam and pour the alloy in the cut area. And you may have to tilt the patient to bring it perpendicular to the beam so that electron field is taken care of. This was my input.
Okay, sir. Can I go
Yeah.
ahead? So this is about this heterogeneities, and to decide using field-in-field IMRT or VMAT. Yes, we will prefer field-in-field. If everything is good, we start with field-in-field. If not, then we will go with IMRT or VMAT, depending on the concavity of the target and the OARs, proximity of the OARs, and length of the treatment also. And sometimes, because we have a HDMLC, so sometimes because of the limitation of that what you call treatment field, we may need to go for VMAT or inverse planning. So, but we first prefer to do with field in field, because we know with field in field we can achieve the minimum low dose area in the organ at risk.
And I agree with Kartik, when you are using field in field, and if you are using DIBH, the treatment time will be very shorter also.
I'm starting. Okay, then what are the current challenges in achieving accurate target delineation and OAR contouring, and how can AI tools assist in improving consistency? Okay, to answer this is a very challenging question, I can say, because see, to some extent, OARs, yes, you can do with AI, but as per the target is concerned, it depends on the clinical team, how they are, what you call, they are okay with the AI-based contouring, or they want to follow some other, what you call, other rules or this thing. So it's purely a clinical decision. So, but yes, you can utilize them. So any other questions? I think I have covered the chat box.
Thank you very much, sir. I think there is no more question, but the whole session was very informative. And anyone have any other question? I think, sir, there is no any question right now.
Okay, thank
Uh,
you. Thank you for this opportunity. I believe I have
so,
tried to deliver you whatever has been asked to me. And thank you.
thank you
And
very much,
that is
sir.
from my side.
Thank you, sir. Thank you so very much, sir. So we have taken some initiative for students and DNB students and junior medical physicists, so they can learn and they can get knowledge. And this lecture series will be available on YouTube channel Onco Ocean, so they can access anytime and they can learn and practice. They can improve further, sir. So thank you very much, sir, for accepting invitation and giving such a valuable time for. So thank you very much, sir.
Thank you.
Thank you.
Good
Uh,
night.
Thank you.
लीव कैसे होते हैं? Okay, sir.